Record on this computer. Fantastic. Can everyone see the PowerPoint? Yes, I assume. Adrian had a question. What is Adrian's question?
Oh, yeah. Can you hear me?
Yeah, I can hear you now.
Oh, for that bonus point, is that in person or is that through Zoom?
No, it's through Zoom. I'm sorry.
Oh, okay.
That's what makes it easy for you guys to earn some quick bonus points.
Cool.
Yeah, they're still, Toro University is still not open, so they couldn't do it on campus. So like literally same thing as before, where you just kind of log in, watch it, and pretend like you're here like you are right now. Just saying. I might overtalk you. That might be why I didn't hear you, so I apologize. All right. So everyone see inflammation on the screen? Yes? Yes, good. All right. So the last things we kind of wrapped up with last week was talking about things such as why we are the only qualified individuals to assist with a physical therapist. Also the CPI instrument. Dr. Vresk and I just talked with her 2 days ago about this, the new CPI that just came out. And I guess now the CPI for clinical instructors is even more complex for them. There's a lot more they have to learn, because of course they've attached now continuing education units to you guys. For those that don't know, anytime they take a CI in Nevada takes a student, they now get continuing education credit. So because we added some continuation education credit to it, they had to make everything a little bit more difficult and make the course for a CPI a lot larger, of course. Why couldn't we just leave things the way they are? That would be too easy. But so the CPI is that instrument that you'll be graded on. And then eventually, when you get to your third final clinical, that's where we want you at entry-level clinician, because entry-level clinician means you are ready to go out into the world and be PTAs. That's the ideal goal. Hopefully we get you guys ready to be PTAs. If not, then we failed at our job. So that was what we talked about last time. So now we're going to do a little bit of refresher on some of the stuff from PTA 110, or 110, 103, and from Patho last time. We're going to talk a little bit about inflammation. We also talked about this in a couple other classes as well. Inflammation is a normal body process, right? Inflammation is kind of the start of the injury process. When you bang your knee off something or you sprain your ankle, the first thing the ankle is going to do is go in the inflammation. And it's what also triggers the cascade of healing. You'll hear the term often when you're looking at stuff like wound care books and stuff like that. They talk about the cascade of healing, meaning it starts this way and just keeps building upon itself. So when we have that inflammation kicking in, obviously there's going to be vascular components, there's going to be some fluid components, semi-fluid, and neurological and cellular reactions. So what are some signs of inflammation? What's some of the key components of inflammation? What do you see? What do you feel? Redness, good. Heat, good. What's the other one? Swelling, there we go, good. Right, edema. And when you think of edema, we always think edema is a bad thing, because in physical therapy, we're trained, well, we got to get the swelling down. We've got to get the swelling down. We work so much on getting swelling down. But in reality, what swelling is swelling's the body's natural cast. That's really what it is. So not always the very, very acute phase do we want to reduce swelling maximally. Because what swelling is telling us is, hey, idiot, you did something too hard. You injured yourself. Now stop using that limb for a little bit, right? So if I, for whatever reason, reach out and do something with my hand and end up spraining my wrist, it's going to swell up nice and fat. And the goal of that swelling is to create a natural cast so my wrist stops moving. The problem becomes when we end up in that chronic inflammation phase, right? Chronic inflammation is where we have repeated bouts of acute inflammation that don't go away. Think of somebody that's in lupus or fibromyalgia or anything like that. They're pretty much in a state of chronic inflammation where they just constantly get into the state where they can't get those cytokines and those histamines and everything kind of kicked down and get to move through that cascade of healing. It can also be a sign of scarring, because once they go into that chronic inflammation phase, they start replacing normal healthy body tissue with fibrotic tissue, and that can be the problem with that chronic inflammation phase. So if you localize heat, redness, swelling, and a lot of times there will be pain. Everyone doesn't experience pain the same. If I sprain my ankle, my level of pain is going to be different than if Adrian sprains his ankle. You know, it's going to be different than if Erica sprains her ankle. It's all going to be relative to the person that experiences the injury. You know, it can be catastrophic to one person and the next person just walks it off. And you even see that in professional sports where you hear somebody's got, you know, a high ankle sprain. And they've got a high ankle sprain and one person's out for 8 weeks and the other person just kind of walks it off, gets a little bit of a wrap on it and is back out in the field or back out into the court playing. So everyone responds to this very differently. And we're in that inflammation phase. Remember, that's when all of those enes are coming in. The cytokines, right? The histamines, all those leukotrienes. Those are your chemical mediators of inflammation. It's really important to understand that because when you're looking at a question for your boards that's talking about inflammation, a lot of times they'll ask you, what are the chemical mediators of inflammation? And what you're going down there and looking for is anything that ends in INE, right? Leukotrienes, even though it has an E in there, but all those are your chemical mediators of inflammation. They're what triggers that cascade of healing. So acute versus chronic inflammation. Acute inflammation is usually between 4 to 6 days, follows along with that acute injury phase, right? In the first couple of weeks, we're in that acute injury phase. It's related to the cause of the injury or the trauma, maybe present as pain before the tissue resistance is felt. So a lot of times, you know, say I have acute inflammation of the elbow, I'm going to have pain before I reach my full range of motion because the body is literally saying, hey, buddy, cut it out, let me heal. And when you're in the acute inflammation phase, dynamic exercises are contraindicated. And this is a big thing when we're working with athletes, that if they have a brand new sprain, we're in that acute inflammation phase, we got to back them down. And this can be really difficult with athletes because athletes are just pretty much conditioned to go, 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 go. And if we don't back them down, they may not get through that full cascade of healing. That injury may never heal. And then they end up in the chronic inflammation phase where they're never going to be back to sports. So that's why we kind of have to tell those athletes, look, I know you want to get back to soccer. I know you want to get back to tennis. I know you want to get back to golf. Is golf a sport? But you need to take time off. You need to let that healing effect. It is very hard not to give 100% sometimes. You're exactly correct. Especially if you're at that level where you're starting to do it either semi-professionally or professionally. I know from experience from fighting semi-professionally that, you know, you get socked around a bit and you know that you've done something stupid and you've injured something. It's really hard to say, you know what, I'm going to sit out this match. I need to kind of rest up. When you're like, no, the adrenaline's going, I got to keep going. But with that adrenaline going, you're missing some of these signs of inflammation. That can lead to a more negative outcome overall. Chronic inflammation, you usually say chronic inflammation is repeat bouts of acute inflammation over 6 months. And then it can last 6 months to a year to permanent, right? There are patients that end up in acute inflammation that stay in acute inflammation forever. If you don't play, you get replaced. You're exactly right, Dylan. That's one of the downsides, right? Especially in professional sports, right? You look at the NFL, you know, running back goes down. There are 3 other guys just waiting and biting at the chance to try to take his job. And it's nothing against that running back that was a good player, but the other people want a shot too. I look at a lot, I really, really have a serious dislike of the Patriots. I have for a very long time. It has something to do with being the East Coast, and pretty much everyone on the East Coast hates the Patriots except for people from Boston. But I remember when the Patriots had Drew Bledsoe as the quarterback. Bledsoe was, just a tremendous quarterback, right? He was a really, really good quarterback, but he goes down, gets injured slightly, and they bring in his understudy, Tom Brady, and, well, the rest is history. No one knows who Drew Bledsoe is anymore, right? But everyone knows who Tom Brady is. Yeah, a ton of pain pills. You're exactly right. Or pain shots. That was at least big when I was coming through this, when I played high school sports. It's amazing how much the team doc gave you a pain shot just to get you through the game. And the downside to that is once you've numbed the area or once you've gotten that pain shot and you kind of inure the brain to that pain, which is your body's way of telling you, hey, pay attention to your knee, pay attention to your ankle. But you numb that out, now you just injure it worse. Varsity blues is a great example, right? That's yeah, I mean, and that's sometimes what we have to do is, I mean, we have to, as athletes, when you're in that professional setting, you kind of have to stand up sometimes to that and say, look, no, you're not going to give me a shot. You're not going to do this. It's going to permanently injure. And it can be kind of devastating to those people. And you got to realize when you guys as PTAs, if you ever get a chance to work with professional athletes, and when I say professional athletes, I'm not talking about just paid athletes, because I honestly consider collegiate athlete level professional athletes. They just don't get paid for it, right? And honestly, it's funny is that, you know, the collegiate sports are the only sports where not only do they not get paid to perform, but they have to pay to play because they have to pay their tuition. Think about how kind of messed up that is, right? They pay tuition to go to school so they can perform on the field or on the court to make the universities millions of dollars, right? And they get injured on that. They may never have a professional career for the rest of their life. But when you're working with those athletes, it's really hard to lower them down. And the coaches are right there with you, right? Coaches are really bad about this. Coaches, you know, the coaches have the best interest of their players at heart, but in reality, what they have is the best interest of the team at heart. They want to know if the player can get back to playing so we can get back to status quo of the team. It can get really difficult. And a lot of times the athletic trainers and the PTs and the coaches don't always see eye to eye. Temperature, right? There's going to be a temperature change in response to that inflammatory response. We talked about it. Normally, there's an increase in temperature locally, and it's mild to moderate, so it should be warm to the touch. Overall, that temperature will start decreasing it, especially if you rest the injury or you ice the injury. The temperature will return to kind of normal. Now, when you become with fever or febrile, or pyrexic is another term, that's a systemic response to inflammation, right? When's a common time that you end up with a fever? When you have a what? Some sort of flu, virus, cold, right? A lot of times you end up with the fever, and what the body's saying at that point is something is systemic wrong with me. It's not like when you get the flu, you can look at your elbow and go, oh, well, that's what's causing my fever. No, when you get the flu, it's your whole body that's causing your fever. But be aware that that elbow, still depending upon how you injured it, can cause a systemic fever, right? So say maybe I got a really nasty road rash on my elbow, and I didn't realize it, but I got bacteria in that wound. Well, because I've got that bacteria in that wound, that can kick up a systemic response to that inflammation and cause me to become pyrexic or have a fever. All because I got something in that wound that my body's reacting to. Initial examination and evaluation should note any abnormality in temperature, so we need to actually check for stuff like that. Ask them how long they've had a fever, right? This is going to become big, I think, from now on. I wouldn't doubt that from now on, when we have patients reporting to physical therapy clinics, that we're going to be doing fever or temperature checks on them. I can tell you guys that will be 100% true for you guys when we return to campus, is that from now on, you guys will go through main campus to start your day, and you'll be fever checked coming in. And it's nothing against you. It's just trying to prevent the spread of any infection to the rest of your class. I was reading about, I think it was Florida Atlantic University. I can't remember which one. It was Florida Atlantic or Northern Florida University or something like that. They went back to classes 2 weeks ago, and they just had to re-shut down the school because 3 or 4 people came in with COVID, and now that's rampant through the whole campus. And that's what we're going to try to prevent with PIMA, is keeping it from constantly reoccurring and reoccurring and reoccurring. Depending on how long the fever is, will tell us what's going on with the person, right? But remember, once you have a fever, even when you have that systemic infection, typically, once you get that fever, you've already passed your communicable phase. Yeah, it is crazy, right? Once you develop that fever, a lot of times you're already out of that communicable phase. That's what's scary about COVID right now, right? I know that we're going to try to keep somebody out that's got a fever just because of precautionary, but once they've got the fever, they've already moved into the inflammation phase. They're mostly out of the communicable phase because for the time that you're the most transmittable to all your friends, you're usually asymptomatic. So that's the scary part about some of these diseases is you're spreading them when you don't even know that you have them. Yeah, cowbell works sometimes. Usually Tylenol works a little bit better, but cow, I guess, can work. Other symptoms we're going to look for is any rash, any cough, any sore throat, note any patterns of fever, right? Now, normal body temperature is 96.8 to 99.5. We usually don't say a patient is febrile until we're over 99.8. Just because at the 99.8 phase, we know we're really getting that fever response going in the body. When you're working with patients, you should know your patient's normal body temperature, right? I know myself, I usually run about 96.9. I'm a little bit on the low side. So when I'm in the 99s, I've got a fever. But some other people, you know, they may run 99.1, 99.2, and they're not febrile until they're over 100. It's not anything right or wrong about the person. It's just the way their body chemistry works out. So signs of fever. General malaise. I love that term. What does malaise mean? It's a really fancy term for what? Yeah, people from Malaysia. Good job. Yeah, malaise is the fancy term for feeling like crap. That's really what it is, right? Malaise is that kind of just, oh yeah, I'm just drained, right? Headaches. Some of you have that now, and every time you hear my voice, it just gets worse, right? Increased pulse, increased respiratory effect. Chills, right? Chills can a lot of times be the effect of your body temperature being warmer than the ambient air temperature. Yeah, mal means bad in French, right? Anything malignant is bad, 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 right? Shivering goes along with chills. Piloerection. Uh-oh, I didn't think we'd be talking about this. Piloerection. What's piloerection? Yeah, goosebumps and your hair standing up, right? It's not what you think it is. Piloerection is kind of that goosebumps, goose flesh, and then your hair standing up on end. Insomnia is common with fever because the body doesn't like to be warped. Excuse me. Weakness will come with it, loss of appetite, their pallor overall will change, their color will change, nausea, irritability. This just sounds like my natural state. Restlessness, constipation, well, maybe not. Right? Sweating, thirst, a coated tongue where it kind of feels kind of dry and cakey, and overall decreased urine output. Now, a lot of times decreased urine output and constipation is kind of a side effect of fever because you're nauseated. And because you're nauseated, you're not drinking. So because you're not drinking, you get constipated and have decreased urine output. This is just one of those where is it the chicken or the egg that's causing it? So if we notice patient has fever, we're going to gather it, we're going to document it, and report the fever, right? Especially nowadays. Patient comes in and has a fever, the clinics are going to have very, very strict guidelines on what's going to happen with that patient. Do we continue treatment? Do we not continue treatment? I think really good clinics will say any patient that has a fever goes home. Now comes the question, do we bill those patients for those appointments? Because one of the problems that we have in physical therapy is people being compliant to their appointments. And so then the patients start using, oh, I have a fever as an excuse not to come to physical therapy. I don't know. I don't know the answer to that. These are definitely going to be some things that we're going to encounter in the kind of post-COVID world. So infection control, hand washing is the most effective means of controlling the transmission of infectious disease, right? You should be hand washing for how long as clinicians? How long should you be washing your hands? At least 30 seconds, right? Good way to do it is to do what? Happy birthday twice, right? It's also the, just to let you know, for those of you that are a little bit, that happy birthday doesn't work for you, it's the whole chorus refrain from the Black Parade is also 30 seconds. So just in case you want something different to sing while you're washing your hand. Treatment areas should be properly cleaned and disinfected routinely. You need to know what type of disinfectants get used for what, because not all disinfectants work on everything, right? What's the most effective disinfectant? What will pretty much kill anything? Bleach. Yeah, bleach kills everything, including good stuff, right? Your normal flora and fauna that you have in your skin, bleach will kill that. So bleach is really good at killing stuff. The downside to it is bleach is really good at destroying stuff, right? Have a nice pair of black scrubs and accidentally spray them with bleach once and watch them either A, become pink, or B, become, you know, Catholic scrubs and get holy. So bleach is kind of, I made somebody laugh, good. Bleach is one of those things that's really good for removing the majority of infectious diseases out there. But again, it's not the best option when we have other germicidal wipes and stuff like that. We can have Lysol wipes, but those Lysol wipes are rated for a certain amount of diseases and may not kill something like C. diff, right? Did you guys learn about C. diff? Yeah, there we go. Thank you. It was coming slowly. It's a little bit of washing head today. So have you guys learned about C. diff last semester? Worst smell ever, right? The first time you encounter C. diff, you will never ever forget C. diff. I guarantee it. I wouldn't say it's the worst smell ever, because honestly, I think gas gangrene is worse than C. diff, because C. diff just smells poopy. Gas gangrene is its own unique odoriferous emanation. You know, gas gangrene is where the skin literally is necrotizing and melting. So, the yummy smells you guys will get to deal with in physical therapy. Fever and exercise. So, how many of you guys have heard if you have a fever, you should not exercise, or if you have a cold, you shouldn't exercise? Did anyone hear that? Right. So, in the acute phases of fever, right? So, and some people say that, sweat it out. In the acute phases of fever, when you first notice your fever, you should not be exercising. So in those first couple of days of having a fever, you shouldn't be exercising. There are two reasons for that. Exercise kicks up your inflammation cycle. So if you're exercising, your inflammation cycle is already heightened, all you're doing is just kicking it up even further. Again, the other side of that is, in those first couple days of inflammation, you're also communicable. So, oh, I'm going to go to the gym and sweat it out. Well, fantastic. You just spread your virus to everyone in the area. So you want to make sure that in the first 2 or 3 days, you kind of kick back. Now, once you get past that, you usually can get back to exercising. Just moderate your exercise. Feel your body getting too warm, kick it down. Fever and lymph node pain, right? Any pain in the lymph nodes. Where are your lymph nodes at? Other than all over the body. But where are your ones you're usually worried about with illness? Yeah, neck, right? Kind of right around that Adam's apple region. Where else? You have 3 main areas you can check for lymph node swelling. You can check here. You can check here in the armpits. And the last one is down in the inguinal region, in the inguinal canal, in the groin. All of those are kind of 3 main areas of lymph node drainage, right? So you have the upper extremity, lower extremity, and kind of the head and neck. Any pain, tenderness, enlargement of lymph nodes, even without fever, indicates you may have a systemic infection. That usually means that the lymph system is fighting off an infection. Erythema. fancy term for redness of the skin. It is also part of this inflammation process. You can also have stuff like rashes, red streaks, redness with superficial tenderness, loss of skin color where we get paler pallor, bluing or cyanosis. If you see bluing or cyanosis of your patient, what does that tell you? What's happening if they get blue or cyanotic? Yeah, they're getting lack of oxygen. And then also skin color may depend upon the natural skin tone of the person, right? If you've got somebody who's got a very dark skin tone, it's really hard to see cyanotic skin changes. You know, we may watch for somebody who's got a stroke, we may watch their lips for cyanotic skin changes. Well, if somebody's got dark skin, you're not going to see it easily. Well, the thing is, everyone, if you flip the inside of their lip open, it's really easy to see cyanosis on the inside of the lip because everyone's inside of their lip is pretty much the same color, which is another area you can check for color changes. DVTs. And most common DVTs occur in the calf. What are DVTs? I know it says deep vein thrombosis, but what does that mean? Yeah, it's a blood clot, man. Right? It is what's the difference between a thrombus and an embolus? Because they're both blood clots. Yes, thrombus is in situ. It's in place, right? Emboli means it is now broken free from wherever it was and it has taken a trip, right? And most of the times it's going to take a trip either to the lungs or the brain. Either of those places, no bueno. So DVTs, usually caused by a blood clot in the veins, may break free and travel through the bloodstream, can lead to what's called a pulmonary embolus, where that blood clot will eventually go and find a new place to hang out, usually in the lungs, and block off some alveoli, or blood clot in the pulmonary artery, or anywhere in the brain. Does anyone know the test we do to determine if a patient has a blood clot in the calf? What that test is called? Yes, well, close. Homan sign, right? H-O-M-A-N-S. Not human sign, that's something different, right? Homan sign. So how do you do a Homan's test? Did you guys learn about this yet? Okay. So Homan's sign, what the first thing you're going to do is you're going to look at the patient's calf, right? So you're going to look at both gastroc heads. So physically roll up their pants leg and look at them. You're looking for red, shiny skin. Now, it doesn't have to be shiny, but shiny is a good sign of it. But a bright red skin, and then you're going to palpate it. Does it feel warm? And the last thing you're going to do is you're going to put them in slight dorsiflexion, place your two thumbs, and press down between the gastroc heads. If they have a DVT, what do you think will happen when you press down between those calves? Yeah, ouchie. Yeah, they're usually going to jump away from you or withdraw. Now, is that 100% accurate? No, it's not 100% accurate, right? But it's accurate enough to give us a sign that they have a blood clot or a DVT in their calf. And if they have a DVT in their calf, what kind of physical therapy should we be doing with them? If we suspect they have a DVT in their calf, nothing. Yep, that's where we wave off. Nope, we are not doing physical therapy today because any movement we do with them can free that DVT to become an emboli. So that's where we're going to go out to the nurse and say, hey, nurse, come in here and check, especially if you're in the inpatient setting, right? I think the patient's got a DVT in the calf. And then they're going to send them off for imaging to see if they've got a calf. They're going to actually do an ultrasound on that leg to see if they can see if they've got it. It is better to err on the side of caution and worry that your patient has a DVT than it is to not. I can speak from experience. I had a patient I was working with. The lady was 575 pounds. So she wasn't a small person. I'm just saying that. Doctor came in there. I was reviewing the chart. The OT was sitting at the desk with working on another patient. And the doctor came over and said, you guys need to get her out of bed today. Okay. So we looked in the chart. No indication that she's not supposed to be out of the bed. Doctor's giving us orders to get out of bed. The OT's like, hey, let's just go in together and work on getting her out of bed together. Great, no problem. I'll come with you. So we go in and we had a tech with us whose job was strictly to manage the chair because we had some chairs that when you lock the brakes, they didn't always stay. Real safe equipment, let me tell you. But anyway, we get the patient up and we get her sitting at the side of the bed. Everything's going fantastic. We get the patient standing. Everything's going fantastic. Start taking little baby steps over to the chair. She gets her bottom on the chair and the tech stopped paying attention for 5 seconds. This is why, again, don't put your whole career on techs. Stop paying attention for 5 seconds. Patient sat down on the edge of the chair. Her butt hit the edge of the chair and shot the chair across the room so hard that it embedded the chair into the wall. Like literally the top of the chair was 3 inches deep into the drywall. It was great. And patient ends up, boom, down on her bottom. All right, we've got a fall. And you're expecting the patient to be all angry. Nope, she is laughing her head off about this whole thing because she now realizes that we have to get her up. And she's cracking jokes, and all of a sudden, I'm sitting down there with her, and her eyes roll back in her head. And she starts seizing. Turns out she had blood clots in both of her calves, and the actual vascular doc didn't say anything. He didn't put anything in the chart indicating it yet. He had forgot to do his documentation for the night before. So we didn't even see that that patient had blood clots. And when we finally saw, so we started doing CPR. We ended up having to do CPR on her for like 5 hours. We kept getting her pulse back. She kept fading away. Pulse back, fading away. When they finally did put the actual information in about the blood clots, she had blood clots that ran from the base of her heel all the way into her groin. So basically, her whole vascular system in her legs were nothing more than blood clots. Yeah, wow, right? Now, she didn't show any typical signs of blood clots. She was doing okay. I mean, in a patient that big, it's really hard to look for signs of blood clots too, because there's a lot of tissue, right? But we suspect that the patient's having blood clots. We're going to waive off. It's better to waive off and protect your license and come back later in the afternoon than it is to get them up and throw a blood clot. Because for me, I had to go before a sentinel committee then and explain why my patient died. And just saying, well, the vascular surgeon didn't tell us that there was blood clots isn't a good enough excuse, right? So you've got to take some ownership for it. And the PT had to come with me as well, which was loads of fun. My PT loved me. So risk factors for DVT, any immobility, right? Even something as simple as being immobile on a plane can lead to it, right? Why are people more likely to get blood clots when they're on planes? They're not moving their legs, good. What else is changing when you're up in the air? Yeah, the lower atmospheric pressure, good. The elevation changes, and then the blood kind of just pools, right? So any immobility can cause blood clots. Trauma, right? If I get something that smashes off one of my veins, definitely going to lead me to having probably DVTs. Diabetes is a major, major, major risk factor for blood clots. Obesity, and then if a patient has a prior DVT, they're likely to develop new DVTs. And then lifestyle, right? Unfortunately, ladies, any type of hormonal replacement or oral contraceptives, that can lead you to getting blood clots, especially if you have other risk factors that go along with it, right? So if you have other risk factors like family history of blood clots, and then you're on oral contraceptives, and then you get in a plane, I would say keep moving, right? Hypercoagulation can also cause it. Any problems where your blood just is thicker than normal. What can you tell a patient to do? Birth control. Yep. Birth control is a great thing because it prevents parasites, right? Because Yeah, exactly. Can lead to stroke. You're right, Eric, and it's nice. Thank you for sharing that. It's amazing what birth control can cause to happen to your vascular system. Kids are parasites. You're 100%. Look at the definition of a parasite. Parasite is a foreign body that feeds on the host. That's a kid. But you know, those oral contraceptives really affect your clotting factors, your blood. And so when you're on those, a lot of times you just got to be careful, right? What can you have? Say you have a patient you know is at risk for blood clots. What can we recommend them do if they're going on a long plane ride? Get up, right? Good. What else? There's 3 things we can recommend. Yeah, compression socks, good. And then ankle pumps. Yep, those are the 3 things we can do. Get up as frequently as possible, ankle pumps, and compression hose. Do all 3 of those, it lessens their chance of getting a blood clot. And never say, it'll keep you from getting a blood clot, because they will remember that. Right? Tell them it's going to lessen your chance of getting a blood clot. We can't fully prevent you from getting them, but this can reduce your overall effect and chance of getting them or getting really bad blood clots. Even just sitting here at home, you know, doing ankle pumps is good for you, just to keep you from getting it. Edema, right? Definition of edema is excessive pooling of fluid in the spaces between tissues, or interstitial spaces, right? When you see interstitial spaces, it's nothing more than the fancy term of space between tissues, right? Measure the edematous part or extremity. When we see swelling, a lot of times what we really need to do is measure the swelling, right? You guys learned a little bit about that in modalities, where you guys did some measurements with the figure of 8, right? And just general girth measurements are going to be big there, right? And why are we going to measure? Well, we want to compare day to day. If they're in today and they've got really bad swelling, we want to see if it gets better tomorrow or if it doesn't get better tomorrow. All standard measurements are going to have specific standard landmarks to go off of, right? So let's talk about the knee, because we're going to talk more about that when we do anthropometric measurements here in a little bit. With the knee, the main thing you're going to find is the dead center of the knee. Where is the center of the knee? What are we going to use to measure the center of the knee? Yeah, the patella, right? We're going to find that inferior angle of the patella, the superior angle of the patella, right? And measure between them. That's mid-knee or at that joint space. For the most part, in extension, it's at joint space. When we're measuring joint space, we're looking for true swelling. A lot of times we'll go 2 inches above and 2 inches below. If we're measuring those 2 inches above, 2 inches below, we're still measuring for joint effusion or joint swelling. But sometimes you'll see that then we'll do 4 inches above and 4 inches below. Does anyone know what we're measuring for at that point, once we get 4 inches above and 4 inches below? Girth, yeah, obviously. We're actually measuring muscle, right? We're measuring atrophy to go along with that swelling. Atrophy or hypertrophy, depending on what we're doing, right? Because we all want to get swole, or at least most of us want to get swole. And so knowing what your muscles look like can help you understand if you're getting progress from what you're doing. So you guys got to know how to measure, right? You got to find that bottom until you feel the bottom of the kneecap, top of the kneecap, measure between it. At the ankle, what are our measurement points at the ankle? You remember the measurement points of the ankle? What are our bony landmarks? There are 4 of them you need to remember. Lateral and medial malleolus, there's 2 of them. Good. Yep, base of the 5th met head. And what's the last one? You're on a boat. Yes, the navicular. Right, so navicular tuberosity. All of those are your standard landmarks for measuring at the ankle. We're going to do some wrist measurements as well. And guess what? At the wrist, there are standard measurements, right? we're going to have very specific bony landmarks we're going to use for measuring at the wrist. The shoulder, there are very specific bony landmarks for measuring the shoulder. So all of those are going to come into play when we're measuring swelling. When we're talking about edema, we usually describe it as, specific. Is it brawny, meaning is it very, very hard to move? Is it pitting? What does pitting edema look like? I should not have this stress toy. I'm going to be playing with it the whole time. What's pitting edema look like? Has anyone ever experienced somebody that's got pitting edema? Yeah, it's like membrane foot. It stays depressed when pressed, right? It takes a little bit to kind of rebound. It may even just stay there, right? Dependent edema is something that we all are getting right now. If we measured your ankles before you sat down for this class and then at 12:30, you're going to have some dependent edema. That's because there is going to be some fluid that is going to collect in your feet because you're not moving as much. Right? That's what dependent edema is, from just being down and below your heart. You can adjust that by just moving. So we can do circumferential measurements, which is what you've been trained on by using that tape measure and measuring around it. We can also do water displacement, where we put the patient, that's okay, Erica, it's fine. That's why we record it. We can also use, that water displacement method to determine how bad their swelling is. The main thing we want to worry about with edema is making sure they don't get compartment syndrome. Has anyone seen anybody with compartment syndrome before? Anyone? I know some of you guys are techs. I don't know if any of you had encountered somebody with compartment syndrome or not before. So compartment syndrome sounds exactly like it is. It's going to be one specific compartment of the body. Usually it's the calf. I've seen it in the forearm. I've seen it in the upper arm as well, where anatomic components, those compartments, get fluid trapped in them. And then as that fluid traps, it starts spreading out and pushing against the fascia, right? And because the fascia has nowhere to go, it doesn't give, and then the only way it can actually start squeezing next is in, right? Once it starts squeezing in, the body's going to start pruning off tissue, specifically blood vessels, muscle, any really deep levels of the dermis, any adipose. And it's actually going to cause ischemia in that area, and you actually have a high risk of losing the limb. So when a patient has this compartment syndrome, it is a medical emergency, and a lot of times they're going to do a fasciotomy. Has anyone heard of that before? Nope. Fasciotomy is exactly like it sounds. They're going to lay open your fascia, and they're going to let that excess extrastitial fluid just kind of seep out. We had a student a few years ago in one of the cohorts who ended up with compartment syndrome in both her calves from running. And they had to put 7-inch gashes in the front of her leg and the back of her leg to allow the fluid to seep out. And they left those wounds open for like 3 days in order to allow that swelling to kind of leak out so that the rest of the tissue didn't die. And she had some pretty gnarly scars from it. But, when you ask her, is she upset about the scars? She'll say, I would be more upset about losing my legs. The good news is there's treatment for, this compartment syndrome. The bad news is we have to be able to recognize it. Oh, pain. That's what you're having right now. So, when you guys are assessing pain, what do you need to get about pain from a patient? What are the key things you need to get? Right, acute or chronic, right? When did the pain start? Good. On a scale of 0 to 10, what's your pain level? So is it acute or chronic? Scale of 0 to 10, what's your pain level, right? Can you take one finger and, as Renee said, can you point to it? And when you're documenting in your notes, you need to use anatomical terms, right? So let's say I'm like, my pain is right here. How would you describe that in a SOAP note? What would you document that as? Say I've got pain that's 9 out of 10. Could be supraspinatus pain, right? I would say near the, what joint am I near? Yeah, the AC joint, right? So that's things you got to be thinking about. Like if I say I've got pain here, right? I've got pain near the what condyle? Yeah, the medial condyle, right? So I've got pain near the medial condyle of the humerus. You've got to be specific because I've got 2 medial condyles, right? So all of that comes into play. Once we've got, is it acute or chronic? What's the level? Where is it at? The next thing we have to get is what type is it, right? So what are just some descriptions of pain patients can give? Noxious pain, good. Most of them won't say noxious. They'll all say it's all noxious. Is it sharp? Is it stabbing? Is it achy? Is it dull? Is it throbbing? Is it electric-like or burning and tingling? All of that gives us clues as to what type of pain it is. And a lot of times that's what you need for your SOAP notes, right? One of the other things you can get that kind of gives you a clue as to what the patient's doing is, what makes it better and what makes it worse? Oh, well, when I put ice on it, it gets a lot better. Well, duh, they're numbing it, right? Oh, when I'm running, it aggravates it. Great, that tells us maybe we want to watch how much extra activity we do with them. So all that comes into play with pain. Assess not only at the site of treatment, but patient's overall response. If I'm coming in and I've got shoulder pain, because that's my treatment area, so I've got a right AC separation or something like, well, right AC separation. And I say, yeah, I've got pain on shoulder. I've also got some low back pain. Document both. We may not be treating the low back, but you still want to document that the patient had pain elsewhere. Could pain in the back be caused by the shoulder? What do you think? Got to get back pain? Yeah, maybe, right? So now instead of, reaching up with my shoulder, now I'm really stretching with my back and I'm straining my back. So definitely I could really hurt my back by doing stuff like that, especially if I've got pain in the knees or the ankles. I definitely can get low back pain, right? That's going to be one of those transfers of pressure. Relaxation techniques maybe need to be included, right? You wouldn't think that you're going to teach meditation, but a lot of times we're going to teach a little bit of meditation, right? We're going to teach them, okay, let's breathe through some of that pain, right? We're going to go on to kind of like Lamaze for PT patients. All right, let's take some deep breaths in, some deep breaths out, and let's try to control that pain. So this is so when I put this normal pain on here, then what I'm saying is we've been conditioned over probably the past, probably 94-ish, so that's quite a while, that pain is an abnormal part of life, that we shouldn't have pain, right? That if a patient has pain, we need to relieve that pain and get them to 0. A lot of times we're never going to get to 0. Right? Patients, we have to convince patients sometimes pain is just a part of life and you live it. If I ask all of you guys right now, I'm sure that a lot of you have some form of pain that you live with on a daily basis, right? For me, with a broken neck, I definitely just kind of function at about a 6 or 7 out of 10 almost every single day. Between that and getting a migraine, it's just normal life, right? And people can learn to live with pain. But there's been so much push, especially from the pain medication side of things, that pain is an abnormal finding and we need to get rid of pain entirely. So how do we get rid of pain? Here's the pill. Oh, that pill gives you problems. Well, here's another pill, and here's another pill, and here's another pill. We don't want that. Now, let's say we are working with a patient and their pain goes up. Is that always a bad thing? You know, say we're exercising this patient and their pain goes up. Yeah, it's not always a bad thing, right? My martial arts instructor used to say all the time that pain is the body's way of thanking you for using it, right? But you have to understand good pain versus bad pain, right? You go to the gym, if you had a really, really hard workout, are you in pain typically? Yeah, typically you're in a little bit of pain, right? You're a little bit wore out, you're a little sore, you're a little achy, you're a little cranky, and gosh darn it, that guy in the freaking locker room just wants to talk to you. That old guy that's walking around nude the whole time. He just wants to talk to you. Leave me alone. I want to get a shower, right? That's a normal process of the body, is we just kind of get a little bit of pain as time goes on. We can deal with it, right? We walk it out, we stretch it out, and we do some post-workout stuff. But we do want to observe pain in our patient. If we see changes in pain, we need to document those changes in pain. Does it go up? Does it go down? What caused it to go up? What caused it to go down? We also have to understand this general A&P of the body so we can apply this information, right? We need to make sure that we have a good grasp of anatomy. That's why anatomy is one of the first classes you guys have. So referred pain. Referred pain is pain felt in an area far from the site of the lesion or the problem, but supplied by a similar or adjacent neural segment. This is a fancy way of saying referred pain is typically pain somewhere else that's along the same dermatome. Right? Do you remember learning about dermatomes somewhere? I think I talked about it. Right? I told you guys that one of the things you guys want to make sure you get out of anatomy is understanding your dermatomes, right? Can originate from any skin, somatic, or visceral source. Let's say right now I started having a heart attack. Is it always going to be that I'm going to start having chest pain? No, right? I may have no pain, especially if you're a young lady. Most times you don't have chest pain, right? What are some symptoms that I might be having a heart attack on you guys right now? What kind of pain symptoms, right? I may be complaining about shoulder pain, right? Well, I'm kind of screwed because I don't have a feeling in this arm, so guess I'm out there. I start having a heart attack, sweating, right? Where else can my pain be referred to for heart attack? You're referred up into the left aspect of your jaw, right up into your head. Typically, this whole left side of your head can lead to it, right? For ladies, the most common complaint of a heart attack is they start complaining that they feel like they've got indigestion. You know, I've got a little indigestion today. Oh, just a little bit of indigestion, right? My mom's excellent example of it. I remember when the day that my mom had her major heart attack that she needed her quadruple bypass, you know, we were walking around the mall for probably 7 or 8 hours because she wanted to go to the mall. And if my mom wanted to go to the mall, you went to the mall with her just because that was what you did. But we were walking all day long. She kept complaining about having indigestion. And when she finally actually showed signs of that, a true heart attack, and we got her to the hospital, like, she probably had 20 heart attacks all day long. But she just felt them as indigestion and didn't think anything of it, right? So pain, that referred pain can be very different, right? And did Dr. Johnson talk to you guys about referred pain sites? Good, right? Know them. It's not a huge part of your boards, just to let you know. So that's one of those, if you don't know it as well, don't totally freak out. You can review it by the time we get to the boards, right? There's not a lot of referred pain sites. But it's important that you understand that pain can be referred elsewhere. It's commonly associated with problems in the musculoskeletal system. It's often felt deeply and radiates segmentally, right? Visceral pain. This is pain that originates from a body organ. This can come from the heart, from the lungs, from the stomach, right? Has anyone ever in here had really, 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 really bad constipation? You're like, I'm not going to answer that question, right? If you ever end up on opiates, yeah, right there, right? It feels like you're going to die. That is 100% right along, right? And here's the thing, if you're really constipated, eventually, guess where that poop can come out? Just saying. It can back up that bad, right? It's just amazing how that pain from something like that, and there are patients that go to the hospital that complain that they're having a heart attack. Like, oh my God, I'm having a heart attack. And the doc scans them like, your heart's fine. Like, your bowels are concrete, but your heart's fine, right? A lot of times those pains aren't very well localized, right? Like talked about that patient thought they were having a heart attack, right? It's not that they're going, okay, my pain is in my descending colon. I notice that I have pain in my descending colon. No, it's just general. The whole body's like, oh, I'm dying, right? It can also happen if you guys have the opposite of constipation, right? If you get really, 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 really bad diarrhea, right? That could cause a similar effect, right? You can really feel like your whole body is just on fire from it. Trigger points. These are small, localized, tender areas found within skeletal muscles, fascia, tissue, ligaments, periosteum, and periscapular areas. A lot of times trigger points are nothing more than localized pockets of problems with muscles. It can be something as simple as having a little bit of lactic acid. That can be where the actual part of the muscle gets bound down to the fibrous tissue of the fascia. We're not 100% sure what always causes trigger points. What we do know is there are specific areas that have trigger points, right? And TMJ is one that's kind of funny. I always love when a patient says, oh yeah, I've got that TMJ. Because I always joke them like, yeah, I've got 2 of them. Because TMJ is talk about the joint, right? TMD, or temporomandibular disorder, is what they're talking about. But right now, if I have all of you put your fingers back at the base of your joint of your jaw and massage a little bit, almost all of you will go, okay, that feels wonderful. Because you've got latent trigger points there, right? Especially if you're somebody, you know, that likes to talk a lot and they use your jaw a lot, or, you know, you eat a lot. Temporomandibular joint gets kind of inflamed. Cervical strain, right? Everyone go back to the back of your skull. Come down and find those 2 occipital protuberances on either side, and just put a little bit of pressure there. Does that make anyone's head feel better? No? Some of you are like, no, it makes it worse. Great. Well, you've got some nasty trigger points. Some of you will. When we do suboccipital release and we teach you on that, that's one of the things we're going to do is we're going to get in there and we're going to kind of cradle that area and put pressure on it. And when we cradle that area and put pressure on it, a lot of times what you're going to find is these little latent trigger points that are hidden in there, release. And here's the thing about trigger points, which you'll find really easy. Oftentimes you can't release your own trigger points. That's kind of silly, right? But for whatever reason, we have problems releasing our own trigger points. But somebody else gets on those trigger points and they can just, boom, gone in history. Fibromyalgia can cause a myofascial pain syndrome, right? Whenever we note trigger points, right, we want to document them. And by notifying the PT, it doesn't mean you have to stop and run out and get the PT, right? But we want to document them in our notes that patient had a trigger point and use anatomical terms in the mid-belly of supraspinatus, in the mid-belly of infraspinatus, right? All that's going to come into play when we get those trigger point areas. Final note about pain. Don't judge a patient's pain. Right? Now, if a patient comes in and says, I'm in 10 out of 10 pain, and they're just sitting there. Yeah, I'm in 10 out of 10 pain today. Are they really in 10 out of 10 pain? If they're sitting there and they look like nothing's wrong, right? I've got a really funny video I want to show you about pain when we have to take a break. That's great. Just because the humor in it is fantastic, right? But 10 out of 10 pain, really, they should not be responding to you, right? If you've ever seen a mother that gave a difficult birth, that is 10 out of 10 pain. If you ever saw somebody that has a fractured femur, that is 10 out of 10 pain. And trust me, if you ever experienced that, I was present at the birth of my first godchild, because the dad wasn't able to make it, so I was the alternate. That was a mistake. Don't ever become the alternate for some of your friends. Some things you can't unsee. But one of my best friends, she gave birth to my goddaughter, a Raven. And, I'd laugh. My friend is 5 foot flat, 85 pounds, soaking wet, little tiny itsy bitsy girl. And I remember they're like, I want you to hold her hand while she's having her contractions. And she's squeezing my hand, and I'm hearing my bones crack in my hand. And she looks up at me, and she grabs a hold of my shirt, and she's like, drugs! I want drugs now! Okay, I want my hand back. That hurt. Right? Contractions are no joke. Right? The pain that I saw her in was just the most tremendous amount of pain I've ever seen a human being be in, until I encountered somebody on the road that actually had a femoral fracture. And then I'm like, hey, that's pretty close. Right? So I always kind of joke that, mothers and people with femoral fractures, they got dibs on 10 out of 10 pain. I don't say that to the patient, but if a patient says they're in 10 out of 10 pain, there may be times where I say, you really at 10 out of 10 pain? Because 10 out of 10 means we need to go to the hospital right now and get you to the emergency room. And they'll go, no, it's probably like 6. We're not going to judge their pain, but we're going to assess it and report it where the patient says, right? I will sometimes challenge if they say they're in 10 out of 10 pain, because just 10 out of 10 is, I don't think they understand it, right? And that's why a lot of times when I ask them their pain, I qualify it. I'll say, on a scale of 0 to 10, where 0 is absolutely no pain, you're scot-free, and 10 is, I need ambulance to haul me to the emergency room right now, where's your pain level at? If you preface that, a lot of times you'll avoid getting those 10 out of 10 pains, right? Pain is an objective finding of a subjective reporting. That means, objective meaning it's got a number associated with it, but it is a subjective finding. If I went around to this whole classroom right now and punched every single one of you with the same amount of force, not everyone's gonna, I would never do that. I would never strike any of you. Please, whatever, don't think I'm threatening violence. But if I did that, everyone would end up in a different level of pain, because we are all a subjective being. We all experience it a little differently. Some of you may cause me pain back. Vital signs. All right, so we're going to do this. You're going to do this, Dr. Sokel, really heavily, right? You're going to have one of your comps on this. There are objective measurements of physiological status. We want temperature, right? Pulse, respirations, blood pressure, pulse oximetry, right? All of this is going to come into play. PTA should not only know how to measure these vital signs and know the normal ranges, but you should be rapid at it. Understand, you do not get to bill for taking vital signs. So if it takes you 15 to 20 minutes to take vital signs, that's 15 to 20 minutes you lose of treatment time, and you don't get the bill for that. You need to be quick, rapid. You need to be able to get these vital signs in no time flat. The good news is, nowadays, most of the time for vital signs, we have machines to measure them, right? Blood pressure, we used to have to always take them with the old sphygmomanometer and the little blood and the stethoscope and listen to it. Now, most times it's wall related. Stick the cuff on, you press start, right? Or you have one of the little portable blood pressure cuffs you put on them. But you still need to know how to take it manually, because if you don't know how to take it manually, it can be a problem. When patients are exercising, vital signs will change. Does your breathing change when you're running? I hope. That would be a problem if it didn't, right? Your heart rate's going to change. Not only do you have to be skilled at getting vital signs when the patient's at rest, but we also have to be able to measure vital signs if they're in motion as well. And that can be a challenge, right? There's no easy way to get blood pressure when somebody's running. Right? There's no easy way to get pulse when somebody's running. Now we have all kinds of nice devices, right, nowadays that can track most of it, right? My little watch here tells me every day what my pulse rate is for like the whole thing. Like right now it says my pulse was 67 and it was last taken 5 minutes ago. So the good news is we've got this now. They've even got watches now, and I think the next Apple Watch actually has a pulse oximeter built into it. So not only will it give you your pulse rate, it'll give you what your blood oxygen saturation is, which is actually kind of cool. This watch, I have one of the fancier, the newer versions of the Apple Watch. I can actually do a single lead EKG on this watch. It's amazing the tools we're getting with these new devices, right? We can put a halter on them and measure the patient's heart rate the whole time. So there's all kinds of things we can do. We have to get really effective at taking their vital signs. Fatigue. I'm fatiguing a lot of you guys right now. We want to observe and report any abnormal response to activity or exercise. Have you guys learned about the rating of perceived exertion yet? So rating of perceived, I'm probably gonna spell that wrong, but oh well, or the RPE, right? Sometimes it's known as the Borg RPE, but most of the time we're gonna talk about the RPE. The RPE is a good way of measuring a patient's overall exertion and how fatigued they are. Now, the original RPE is on a scale of 9 to 22. So you would ask the patient, on a scale of 9 to 22, how would you relate your fatigue level? The problem is patients looked at you like you were a three-headed monster. Because they're like, on a scale of 9 to 22, what does that even mean? Well, what it was amazing enough, they had actually correlated when they answer those questions on that 9 to 22 scale to cardiac output. So they could actually kind of assess what the cardiac volumetric output was based on what a patient said. Nowadays, a lot of times what you'll see we'll use is not the RPE, but what we like to call the MRPE, or the modified RPE. And this is just like pain level. On a scale of 0 to 10, with 0 being not fatigued at all and 10, I'm ready for bed, where are you at as far as tired or fatigue-wise goes? When we are exercising the average patient that we are going to see in physical therapy, we need to keep them in that about 4 to 6 range, at least at minimum, right? That means that they're doing some work. Some patients we may want 6 to 8. Some patients we may want to keep under 6. But that modified RPE, or that rating of perceived exertion, helps us assess a patient, right? Multiple sclerosis. If you encounter a patient that's got MS, you're going to ask them, are they in pain? And a lot of times they're going to say, no, I'm not really in pain, but I'm just tired. I'm so tired. Well, that gives you a chance to segue right into that beginning going, oh, okay. Well, on a scale of 0 to 10, like I talked about with your pain, where do you say your exhaustion is right now? That gives you something more you can document. Anything we can add to our documentation helps validate why we are doing physical therapy. Fatigue can be generalized, right? Generalized fatigue being the whole body, or it can be specific to one muscle or one area. Dyspnea. What's dyspnea? Yeah, dyspnea is it's difficulty breathing or shortness of breath, right? That's kind of that dyspnea effect. They're having problems breathing. Chest pain. That could be a sign of cardiovascular fatigue. They may not be having a heart attack, but you may have just worked them that hard that the heart literally is saying, yo, time out, bro. Palpitations, where the heart is actually skipping beats, can be a problem. Headaches can be also a sign of fatigue, right? When your blood pressure goes up, your head usually hurts. Muscle fatigue can usually lead to inability to perform a normal contraction, cramping, or discomfort. I'm sure all of you have gone to the point at some point, if you guys have gone to the gym, where you hit that point where you're doing some sort of an exercise and your muscle says, nope. And you've hit that fatigue point where the muscle just gives out, right? That's when you know that your muscle is fully fatigued. And oftentimes in physical therapy, we don't want to work them that hard. You know, we want to build up the endurance, and working them to their 1 rep max may not be the ideal option. Now, if we're working with athletes, we may. Generalized fatigue may lead from dyspnea, can have decreased ability for the body to use oxygen, and they can also use that RPE, which I just talked about. End feel we already talked about in kinesiology, so I'm not going to go over this type of stuff here. Stretching and palpation, right? In that acute stage of inflammation, do you think we want to stretch a patient? What do you think? If they're in acute inflammation, do we want to stretch them? No, right? Because when we stretch again, we're going to kick up that inflammation. In subacute, we can start stretching them, right? So when we hit that tissue resistance zone, when we get back to the lab, we're going to do some stretching labs. And we're going to stretch each other. You have to understand and be able to not only feel when you get points of tension, but also know when to stop based upon your patient, right? If your patient is laying in bed and they're pulling away from you, you might be too aggressive in your stretching. I will openly admit I am really hard on patients when it comes to stretching. One of the jokes I had in a lot of my clinics is they're like, anyone else but him, please don't let him stretch me, because I'm pretty aggressive in my stretching, right? So when you have that acute stage of inflammation, pain is typically encountered prior to hitting the end of tissue resistance. Subacute phase, pain is synchronous with that end of tissue function, and then chronic, it's usually after. So once you get into that stretch is when you'll get chronic pain. Oftentimes we want to document the extreme degrees of tenderness and the purpose so we can compare it against baseline. A lot of times what we're going to be doing is comparing everything against baseline. And baseline is what the PT is going to determine. Flexibility, right? Loss of flexibility is when the muscles or tendon ability can't reach full length anymore. And end feel is usually described as muscular or tight or muscular spasmy feel. Use the same muscle assessment technique the PT use, either goniometric measurements or know your anatomy and how to conduct this measurement. If you overstretch a muscle, a lot of times you can end up with tendinitis. Has anyone ever had tendinitis in here? Yeah, it's fun, isn't it? Tendinitis is a great feeling. And sometimes it feels like that muscle's ripping right off the bone, right? Tendinitis is overuse of the muscle, right? You can often get, people that do typing can often get tendinitis. Volleyball players can get overhead tendinitis. There's all kinds of ways you can develop tendinitis, right? Golfer's elbow, tennis elbow, all that is just a form of tendinitis. When you have an itis, we need to cool it down in the acute phase, right? An inflammation of the tendons. What is the difference between tendinitis and tenosynovitis? So we talked about tendinitis there. What's the difference? Yeah. Well, it's actually close. So tendinitis is just the tendon. Tenosynovitis is the tendon and the synovial section of the joint, right? A lot of times you'll see patients with bicipital tenosynovitis, right? And what that's saying is, as those bicep tendons are coming out of the shoulder, there's synovial sacs up there that protect it. And all of that gets inflamed and gets sore. Like right now, I can feel it in my long head really bad. Just doing that irritated it. Right? So tenosynovitis is still, you still have tendinitis, but you also now have the synovial joint being affected as well. Bones. When you get a fracture or a break, how can we test for fractures? What can we use other than x-rays? Ultrasound, good. Yep, ultrasound will tell us if they have a break for sure. I guarantee that'll be a fun ultrasound. Tuning fork, yeah, exactly. It's why I carry a tuning fork with me in my little case that I carry, just in case I encounter somebody I think it has a fracture. Smack the tuning fork, stick it on the bone. Guarantee, if they have a fracture, they'll let you know. Usually with a fist, so get ready to dodge it. Because that makes the bone really vibrate and hurt, right? Ideally, we can get it with an ultrasound or we can get it with an x-ray, right? You can even see them in MRIs if the MRI is done right and weighted right. But fractures are often missed. it's really common for a patient to come into physical therapy and, you know, the doc suspects them to have something like plantar fasciitis, and they send them to physical therapy, and really what they have is a calcaneal fracture. Because it's really hard on some of those bones to tell if it's actually fractured or if it's just kind of got some joint effusion and stuff like that. Patient may have point tenderness. Stress and pathological fractures can occur with little or no effort. It's really easy to get a fracture. It really is. Now, the long bones is a lot harder to fracture, right? Your femur, thank gosh, is really difficult to fracture. But as we get older and as we develop pathological conditions, it's really easy to get more and more fractures, right? So that's the kind of thing. What are the fractures called that kids can get? Only kids. Yeah, green stick, right? Why do we call them green stick fractures? Sounds like glow stick. Okay, I haven't heard that one actually. That's actually kind of an interesting thought process. Well, green stick comes from the theory of a tree, right? When a tree grows a new root or new branch, what color is typically the branch? What's green? And if you break that, it doesn't snap like a typical tree branch. It kind of splinters, right? And that's kind of the idea of the green stick fracture. It doesn't break like a normal break. And we've got to be paying attention with our pediatric patients. Joints and ligaments. We're not talking about that kind of joint. We're talking about the joints in our body. We talked about this in kinesiology, and I'm not going to hit roll, spin, and glide again here. But we can get problems in any of those when we're doing any type of TherEx with the patient. Distraction and compression we kind of already covered. With the PTA's role here, we want to report any previously undocumented findings, right? So anytime that we're working with our joints with the patient, any new reportings of pain, we want to report it. Crepitus. How many of you guys experience crepitus in the morning? I know I do. Right? Crepitus is that feeling when you're getting up and you're kind of all crunchy and you got junk in the joints. There's a lot of patients, right? Adrian's like 24/7. Right, so where you move around and things are cracking and crunching and kind of don't feel well. We notice that their bursts are fluid filled. We've got swelling where we shouldn't have swelling. We've got bursitis, any new lumps, any joints pain or any swelling. We want to report those in our notes. Ligamentous integrity. We're going to practice this because we're going to do a couple different special tests testing ligament integrity, right? We're going to test the joint ligaments to see if they're lax, meaning they're loose, or if they are firm enough that they're resisting it. Any type of improper healing will increase the actual chance of having decreased joint stability. Patient may complain that the joint or weight-bearing extremity feels as if it might give out. Well, you hear this a lot with the knees. I'm really worried about doing this with my knee because it feels like it's going to buckle, right? Or it's going to collapse on me. A lot of times, if you have problems with ligamentous injuries, you have sudden edema, heat, swelling, pain, at that point, we need to discontinue PT and let the PT know immediately. What do you think, which ligaments do you think are the most commonly injured in the human body? What locations? Okay, knee, right? Which knee ligament? ACL, PCL, good. And then one other joint. Shoulder, not so much, believe it or not. Shoulder's more usually muscle tendons than it is ligaments. What about your ankle? Did you guys get to look at all those beautiful ligaments in that ankle? It's a mess down there. Right? A lot of times you end up with that lateral sprain of your ankle where you've got those ligaments strained. Because oftentimes when you get a sprain of your ankle, you roll the ankle inwards, right? Or you get an inversion sprain of the ankle. It's really rare to get an eversion sprain of the ankle. If you get an eversion sprain of the ankle, you worked at it. Good job. But the ankle, all those lateral ligaments of the ankle are really common to injury. Gait, right? This is understanding normal walking. We've been watching a lot of normal walking on television lately with all the protests, right? And this is kind of one of my humors is I love to watch these protests and watch and figure out who's got problems with their gait by watching them walk. And you guys will get to this. This is when you start realizing that PT is taking over your life. When you're walking through the grocery store and you're watching people walk and you're like, I wonder what's causing that drop in the right hip. Could it be that they've got a problem with their medial muscles, or what's causing that? That's when you know you're starting to get a little sick in the head and you're starting to get PT really well. So when you start comparing every person you come into count with, right? We're really going to hit normalized gait after we kind of go over posture today in kinesiology. You need to understand normalized gait so you can understand the main thing we're going to hit, which is abnormal gait. We ideally want to get patients back to normalized gait, but we need to know what's causing abnormal gait. That's the main thing we need to understand, right? Compare the patient's pattern of walking to normal patterns. Perform gait assessments, right? With and without shoes. It's really obvious to see patients that have gait problems when they take their shoes off. It's very common that shoes can hide gait problems because a lot of patients will buy shoes specifically that help alleviate some of their gait problems, or maybe they put a shoe lift in, right? We still will look at deviations from pain, weakness, imbalance in muscle strength, everything like that, and we assess components of gait. You'd be amazed at how many PTs are going to pass off gait assessments to us because gait assessments are boring. They really are horribly boring. But they're going to pass them off to us. Go figure out what's going on with this patient's gait and report the findings to me. We're not going to diagnose what's causing them to have a Trendelenburg gait. We're just going to say it's present, and then the PT's got to figure out what's causing it. And last but not least in this lecture, balance, right? Patient must understand and be competent in performing, or PTA must be competent in performing balance assessment, coordination, and agility training. A lot of your job as a PTA is going to be dealing with balance because it's the #1 reported problem in patients 65 and older. The #1 reason why patients that are 65 and older go to a doctor or even go to a PT is because they have a balance disturbance. They've fallen, something's going on where they're not walking right. Well, we have to understand balance is a combination of multiple systems, right? Can be a vestibular system, problem in the inner ear. Can be a musculoskeletal imbalance. Or it could just be generally neurologic and be more central mediated. So we have to understand all of those and be able to tease out individual components that trigger us, right? You all go out on a Friday night when we were able to go out and you go visit, your favorite establishment of dispersing alcoholic beverages. You're all going to, if you go drink, you're going to have a slight balance impairment. It doesn't matter. And with alcohol, believe it or not, at the first drink, your balance is already impaired. Right? That's why 90% of field sobriety assessments are balance related, right? Stand with your feet together, heel to toe. Take 9 steps forward, 9 steps back is a common field sobriety assessment. Pick your foot up 6 inches, point the toes, and stare at your toes. Common balance assessment, right? Because as soon as you have alcohol in your system, your central nervous system gets depressed and your balance gets thrown off. It also dehydrates out your ears, which affects your vestibular system. That gets thrown off, and your balance is going to be screwed up. This is a real easy and quick, dirty way for the cops to check to see if you've got a balance impairment. But we need to be able to tease out, is it an inner ear problem? Is it a musculoskeletal problem? Is it neurologic? And the funny thing we find out with most balance impairments is it's not one. It's oftentimes just a kind of conglomerate of all of those problems that cause patients to have balance issues. All right, we made it through that lecture. Whew. All right, I'm going to get out of the stop screen share here. And we're going to pause.